Dear colleagues, good morning. Today we are going to talk about the Li-Fraumeni syndromes, which is among the most aggressive cancer predisposition syndromes and is characterized by a high and early onset cancer risk. It is associated with a wide tumor spectrum with a high incidence of brain tumors, mainly choroid plexus carcinomas, medulloblastomas, and gliomas. Also, there is a high incidence of adrenocortical carcinoma, soft tissue sarcomas and bone tumors, early onset breast cancer, hematological malignancies, and many other reported tumors in literature. The first report of a familial clustering of multiple cancer inside the same family was published by Dr. Li and Dr. Fraumeni in 1982. And they report about these four families with multiple early onset soft tissue sarcoma and breast cancer. And over a period of 20 years, Dr. Li and Dr. Fraumeni, they defined and better refined the clinical syndrome, which is, has been confirmed by segregation analysis to have a genetic etiology and is now named as Li-Fraumeni syndrome. But it is interesting to go back in time and look at the historical milestones that lead to the demonstration that the Li-Fraumeni syndrome is due to a germline mutation in the P53 gene. P53 gene was first discovered in 1979 during a period of time when the viral theory of cancer development was held in higher consideration. 10 years later, Laviguet reported that 20% of transgenic mice carrying a germline mutation of P53 gene were prone to develop lung adenocarcinomas, osteosarcomas, and lymphomas. In 1996, Pfeiffer showed that induced P53 mutagenesis could directly cause human cancer. And this was one of the first scientific proof. It opened the road to the proof that cigarettes can cause human lung cancer. And there was, therefore, the first step for the change in public health policies and practice in the United States and abroad towards the tobacco industry. So in 1982, we just mentioned it, Dr. Li and Dr. Fraumeni report about the first cases of Li-Fraumeni syndromes. In 1990, Dr. Malkin developed a molecular genetic testing for the P53 germline mutation and start using it as a screening tool to identify patients with hereditary form of cancer. So today, by now, we know that Li-Fraumeni syndrome is a devastating hereditary cancer predisposition syndromes that predispose to multiple early cancer and is associated with germline mutation in the P53 tumor suppressor gene. Mutation in the P53 genes are among the most frequent variants expressed in human cancer. And as we can see in this graphic issued by the Cancer Genome Atlas Pan-Cancer Project, we see that there is a high prevalence of P53 mutations. I don't know if this is something. No. Of P53 mutation across several kinds of tumors, but apart from their high frequency, P53 mutations are highly ubiquitous and associated with various tumor types, and in many cases correlate with aggressive tumor phenotypes and poor prognosis. The P53 gene is located on the short arm of chromosome 17, and it encodes for the P53 protein, which consists of 5 domains. Mainly, we have a transactivation domain, which are required for the transcriptional activity of the protein. We have a central DNA binding domain, which bind with the consensus DNA sequence of the target genes. and we have the tetramerization domain, which regulates the oligomeric activated state of the protein. In the activated state, state P53 binds DNA, as we can see here, as a homotetramer, with 4 subunits. Now, P53 protein regulates a wide range of cellular biological processes in order to maintain the genomic integrity and in order to prevent tumor formation. In response to a wide variety of stress signals, such as DNA damage, hypoxia, oncogenic signaling, the P53 is stabilized and activated. And once activated, P53 binds to a specific DNA sequence in its target genes in order to regulate their expression. Through the transcriptional regulation of its target genes, P53 controls several cellular processes such as the cell cycle arrest, senescence, apoptosis, energy metabolism, synthesis of microRNA, control the stemness, etc., and plays a central role in preventing the tumorigenesis. In this picture, I just want to give you a rough idea of the complexity of the P53 signaling pathway. And as we can see here, we see that P53 acts as a central hub protein of a complex signaling network that controls cell proliferation and death through transcriptional regulation of a wide number of target genes. So it's evident that P53 plays a crucial role in preserving the integrity of the genome, and this is why that deserves the appellation of the guardian of the genome. When P53 gene is mutated, it plays a major role in the pathogenesis of cancer. Somatic mutation can occur in almost every type of cancer. Most of them are missense mutation. Germline mutation are the underlying cause, as we said, of the Li-Fraumeni syndrome. The vast majority are missense mutation, mainly in the DNA binding domain. 20% are nonsense mutation. Now, in the non-stress conditions, the wild type P53 is maintained at a low level in the cell by the degradation proteasome pathway. But when a missense mutation occurs, it leads to the synthesis of a stable mutant protein that is not degraded and accumulates in the nucleus of tumor cells, as we can see here in this picture showing the positive immunohistochemistry for P53, the black spots, in a case of anaplastic medulloblastomas. At the opposite, the nonsense mutation leads to the loss of protein expression. So it seems that the P53 acts as a negative regulator of the growth, of the cellular growth, and it has been traditionally considered as a tumor suppressor gene. And in case of loss of P53 function, we can have loss of cell cycle arrest, loss of apoptosis, loss of senescence, and genome instabilities. But even if we are used to the binary classification in tumor suppressor genes and oncogenes, it seems that the distinction is not so clear-cut, especially when we are talking about the P53 gene, which seems to be a sort of out-of-the-box entity. And indeed, there are recently several studies that show that in case of mutation, the P53 gene acquire oncogenic activities, and the gain of function of the mutated P53 gene promote cell proliferation, anti-apoptosis, migration, invasion, metastasis, and can induce chemoresistance. So, in case of germline mutation of the P53 genes, is there a correlation between genotype and phenotype? Well, it seems that, for example, mutation in the DNA binding domain of the gene cause highly penetrant disease and with very early onset cancers, whereas the opposite, mutation outside the core DNA binding domain are associated with slower rates of tumor development. Also, mutant P53 alleles can have a dominant negative effect, which means that at the heterozygous status, the mutant P53 allele can block the function of the other wild-type P53. Also, there could be genetic and epigenetic modifiers that may also alter the penetrance, the expressivity, in one word, the phenotype of the Li-Fraumeni syndrome. Li-Fraumeni syndrome is inherited in an autosomal dominant pattern. The majority of the P53 mutation are inherited from one of the parents, and only about 20–25% are de novo mutation. Up to date, there have been identified at least 247 different pathogenic variants of the P53 gene with 14 hotspot mutation, and the estimated prevalence is about 1 out of 10,000 births, but this is possibly underestimated. Penetrance in germline P53 carriers has been reported as close to 100% over a lifetime. And as we can see in this picture, with the incidence of cancer according to the age of the patient, we see that carriers have 60% risk of developing the cancer before the age of 40 and 80% before the age of 70, which means also, on the other side, that about 20% of carriers detected inside a familial context may not develop cancer over lifetime. Also, we know that there is a variable penetrance according to the mutation type, and also a gradient of severity among the variants, with the most severe mutation associated with earlier development. So we have to use caution in predictive individual cancer risk in mutation carriers. Here we can see the temporal tumor pattern of the Li-Fraumeni syndromes with the different cancer type depending of the age. And if we focus on the childhood phase, we can see that there are some particular kind of cancer that we can encounter more often, and these are cancers that are otherwise extremely rare in the general pediatric population. And we are talking about mainly of the choroid plexus carcinoma and adrenocortical carcinomas, which are like a signature diagnosis for this syndrome, but also rhabdomyosarcoma and medulloblastoma. So Li-Fraumeni syndrome plays a significant role in the pathogenesis of childhood cancer. And we can encounter a mutation of the germline mutation of the P53 gene in about 80% of rhabdomyosarcoma with diffuse anaplasia, 50% of adrenocortical carcinoma, 40% of choroid plexus carcinoma, 40% of cases of hypodiploid ALL, 10% of the sonic hedgehog medulloblastoma, 10% of osteosarcoma. So, when do we have to suspect the presence of a germline P53 mutation and suggest the testing, the research of the mutation? According to the Chompré criteria, we should suspect the mutation in case of familial presentation, when we have a proband with a tumor in the Li-Fraumeni spectrum with an early onset before the age of 46 and at least one first or second degree relative with a Li-Fraumeni tumor before the age of 56 or with multiple tumors. Also, the Li-Fraumeni syndrome has to be suspected in case of multiple tumors when we have a proband with multiple malignancies of which at least two belongs to the Li-Fraumeni spectrum, again with an early onset before the age of 46, or in case of rare tumor such as the adrenocortical carcinoma or choroid plexus carcinoma or the anaplastic subtype of rhabdomyosarcoma, independently of the family history, and also in case of breast cancer before the age of 31. And what do we do? What should we do when we identify the mutation in a patient? It is strongly recommended that these patients are followed according to the guidelines of surveillance protocol. And here I report the modified Toronto protocol, which suggests for children up to 18 years old to perform a clinical examination every 3-4 months, abdominal ultrasound every 3-4 months again, and once a year, brain MRI, total body MRI, whereas the periodic blood tests are only suggested for patients who received leukemogenic drugs. For adults that are carriers of the mutation, we should perform clinical examination every 6 months, clinical breast examination twice a year, and once a year, breast MRI, brain MRI, total body MRI, abdominal ultrasound, dermatological examination, and colonoscopy every 2 to 5 years. And here in these papers, there are the results from the North American group of the longitudinal assessment of Li-Fraumeni patients over the time. And they have analyzed 89 carriers of the P53 mutation over a time of 11 years. In this study, they had 59 patients in the surveillance group and a minority of patients in the non-surveillance group, and they were able to compare the results. The main reason for declining the surveillance program was not psychological reason, but was very simply the absence of insurance coverage. So they found in the study 40 asymptomatic malignancies in 19 out of 59 patients in the surveillance group. And they also found that there were 84% of patients with the tumors detected by surveillance that were alive, compared to only 49% of patients in the non-surveillance group. They found 2 false positive imagings at the whole body MRI, but most importantly, they found an extensive number of low-grade or pre-malignant lesions that were detected in the surveillance group. And they were able to demonstrate that the early tumor identification allows more chances of definitive surgery and less exposure to adjuvant treatment. So early tumor detection through the surveillance was shown to be associated with an improved long-term survival, as we can see in this Kaplan-Meier curve, where we have a much higher overall survival in the surveillance group compared to the non-surveillance group. Just a few words about the whole body MRI, which has a lower sensitivity compared with target MRI for the detection of small lesions, but it is a very useful and important tool in the, when it is integrated into a multimodal surveillance protocol. PET PET-CT is also effective in detecting asymptomatic tumors, but it is associated to increasing number of false positives, and mainly the repeated irradiation exposure limit the applicability of this exam in the Li-Fraumeni syndrome patient. Now, let's say we are entering the precision medicine era. Could we imagine that in the future there will be a personalized surveillance? It is possible that as large-scale genomic studies will be completed, insight will be gained into the contribution of genetic modifiers and low penetrance mutation in order which will allow to further tailor the surveillance approach. Also, it is possible that emerging biomarkers such as circulating tumor DNA could offer an easily accessible tool for early cancer detection in this patient. And here, close to the conclusion, I will present you just a quick case report of a little girl that was diagnosed in our department with a choroid plexus carcinoma at the age when she was 4 months old. She underwent gross total resection. She received postoperative chemotherapy, 6 cycles associated to intraventricular chemotherapy. And she is now 1 year, after completing 1 year of follow-up since the diagnosis, she's alive without disease. When we were collecting all the information about her family, all the alarms were ringing, because here we have our patient with her choroid plexus carcinoma, but very interestingly, her father had an osteosarcoma at the age of 15 years old, when he was 15 years old, a multiple fibrohistiocytoma at the age of 18. His sister died of breast cancer at the age of 26. Another half-sister died of acute leukemia when she was a child. His father, the proband grandfather, had a liver cancer and brain tumors. So it was evident that we had to search for the Li-Fraumeni syndrome, and the sequencing of the gene in this family revealed the presence of a nonsense mutation in the transactivating domain of the P53 gene, resulting in a premature stop codon, which gives rise to a truncated and inactive P53 protein. So we test the proband, which is a carrier, the father, which is a carrier, the little brother, which is also an asymptomatic carrier. So this case report allowed me to introduce you the issue of the genetic counseling for the Li-Fraumeni syndromes. As in our case, the previous case, after identifying a mutation, the proband parent with any pertinent cancer history or family history should be tested first to establish the lineage of the mutation. Otherwise, both the parents should be tested. Now, siblings and offsprings of the proband should also be tested. If one of the proband parents carries the P53 mutation, each sibling has a 50% risk of having the mutation. But if none of the parents is found to be a carrier, the risk to the siblings is low, but yet they should be tested because there is the possibility of a germline mosaicism. The children of a proband have a 50% risk of carrying the mutation. And so that testing of unaffected at-risk children is a very controversial and delicate issue, but due to the emerging evidence of the efficacy of screening protocols in reducing cancer-related mortality, it is now strongly recommended to perform the testing also in this population. So pre-implantation genetic diagnosis and prenatal diagnosis are available for high-risk couples. And least but not last, there is an important need for psychosocial support for individuals and families with the Li-Fraumeni syndrome. Thank you very much.